This video consent is presented today to discuss the procedure called anterior cervical discectomy and fusion. Anterior cervical discectomy and fusion is a surgery to remove a herniated or degenerative disc in the neck. It involves relieving the pressure placed on nerve roots and/or the spinal cord that causes pain in the neck, shoulders, arms, and sometimes the hands, and in severe cases, legs and walking abilities. Between each bone of the spinal column is a cushion called an intervertebral disc. These discs prevent the bones from grinding against one another, allows us to have motion, bending and twisting, and act as shock absorbers during falls, exercise, and daily activities. Sometimes these discs become damaged, causing pain that can range from moderate to severe. Cervical disc herniations can occur as a result of aging, wear and tear, or sudden stress from an accident, lifting, or other trauma. This surgery may be helpful in treating the following conditions: bulging and herniated discs, degenerative disc disease. Good candidates for the surgery typically exhibit the following: pain, weakness, or tingling in the hand or arm, neck pain due to pinched spinal nerves, lack of coordination, arm pain worse than neck pain, balance and/or walking abilities. Have tried other treatments but have not improved. Your surgeon will examine your neck, arms, legs, gait, and your medical history, and may order an X-ray, CT scan, or MRI of your spine to determine whether your condition requires treatment with an anterior cervical discectomy and fusion. During an anterior cervical discectomy and fusion, you can expect the following. First, you will receive general anesthesia and your neck area will be cleaned and prepped. Next, a small incision will be made either on right or left side on the front of your neck, and the soft tissues of the neck will be separated in order to view the bony vertebrae and discs. Using guided imaging, your surgeon will identify the bones and disc to be treated. The vertebrae bones above and below the damaged disc will be spread apart with a special retractor. Then, the intervertebral disc is removed, and any source of canal compression, whether disc material or bone spurs, pressing on the spinal nerves, will be removed. In order to maintain the normal height of the disc space, the surgeon will fill the space with a bone graft. The bone graft can either be taken from your body or from a bone bank, cadaver. This piece of bone fills the disc space and ideally will join or fuse the vertebrae together. The bone graft is often reinforced with a metal plate screwed into the vertebrae to provide stability during fusion. An X-ray is taken to verify the position of the graft, plate, and screws. In some cases, rather than using a bone graft spacer, another type of device may be used, such as metal, plastic, or a combination of the two. To complete the procedure, the spreader retractors are removed, and the surgeon closes the incision. The operation generally takes between 1 to 3 hours, depending on number of levels treated, and it usually takes a few months for the vertebrae to completely fuse. As in any operative procedure, a number of complications can occur. It is important you be informed of these potential complications. Complications related to anesthesia may occur and should be discussed with an anesthesiologist. Other complications include infection of the incision made to access the bones or of any of the tissue affected by the surgery, infection of the vertebrae or disc space, excessive bleeding, blood clots, nerve damage, spinal cord damage, weakness or paralysis, long-term pain at the location of the bone graft harvest, pelvis, hoarseness and swallowing difficulties, vocal cord paralysis, vertebrae failing to fuse, also called pseudoarthrosis, hardware fracture failure, bone graft migration, adjacent segment disease, failure to relieve symptoms, leakage of the cerebrospinal fluid that cushions the spinal cord, or brain infection. Medical complication, heart attack, stroke, pulmonary embolism. Although most procedures have good results, you understand that no guarantee has been made to you about the results of this procedure or the occurrence of any risks, complications, and side effects. You recognize that during the course of treatment, unforeseeable conditions may require additional treatment or procedures. You request and authorize your doctor and other qualified medical personnel to perform such treatment or procedures as required. You may have other risks that are unique to you. Be sure to discuss any concerns you may have in addition to those listed. You can choose not to go forward with the cervical discectomy. However, if you choose not to have the procedure, your condition may worsen. If that is your choice, you have other reasonable alternatives to consider, including doing nothing, rest, bracing, exercise therapy, physical therapy, medications, steroid injections. These alternative forms of treatment have their own potential risks, benefits, and possible complications. In the case of stenosis, worsening to the point of progressive weakness or bowel bladder dysfunction is a sign of permanent neurological damage. An anterior decompression and fusion at a later point in time may not be effective in relieving your symptoms. You agree that everything has been explained in terms you understand, and all of your questions and concerns were asked and answered. You understand that a successful outcome is sought, but cannot be guaranteed. You are satisfied with the explanations and desire to have the anterior cervical discectomy and fusion performed, knowing the risks. Thank you.